So I just want to briefly highlight some of the key issues in locally advanced non-small cell lung cancer. This actually, we thought we'll place it next to Billy's talk so that we can get some sense of where we are going. And these are my disclosures. I just want to caution that when we talk about locally advanced disease, vast majority of these patients have unresectable disease because they have bulky nodal involvement, multi-station disease, and also they have invasion of mediastinal structures, clearly make them inoperable. And I would not get into this issue of locally advanced non-small cell lung cancer and role of surgery. As all of you know, the most definitive study done by the RTOG intergroup system showed that addition of surgery did not improve overall survival over chemotherapy and radiation. And we can actually debate this ad nauseum as to are there any subgroups that would benefit from surgery, but we won't get into that. We can discuss this at some point. And one important thing to appreciate that is stage 3 disease is not one single group. You have real heterogeneity here, and you have patients who have single nodal involvement on the ipsilateral side. Even that can be occult, picked up only after dissecting 15 stations and eventually finding it in one microscopic focus. Or you can have this, you can see it from about 10 feet with a huge enlarged lymph nodes on the CT scan. So these are all stage 3, but they have going from microscopic instantly discovered N2 to contralateral bulky N3. These are not the same group of patients. There's also some evidence to suggest that the T status can influence as well. So for a given N2 disease, a larger tumor, patients with larger tumors may not do so well as compared to those with a smaller tumor. And of course, the location of the tumor, if you have a left lower lobe disease and then subcarinal lymph node, may not be so bad compared to right upper lobe disease with subcarinal lymph node or AP window lymph node involvement. So clearly the location matters as well. And so it is really important to keep in mind. Of course, the 800-pound gorilla in the room is the biology of the disease. And as you know, cancer evolves in so many different ways, and there are multiple different generations of cells going through division. And by the time you see the patients, it has gone through about 15, 20 years of gestation. So clearly the biological alterations that we see, in fact, the average tumor burden, the mutation burden in a tobacco-related lung cancer is about 250 mutations per tumor if you look at the coding regions alone. So these are really complex tumors. And but one important thing to note is that if you are one of those people who read only headlines and don't read into the subtext, and this is what you would see, compared to 1980, and it was 9 months, and that's the year I went to medical school. And 2015, and now we have inched our way up to about 28 months and overall survival. So you can say, wait a minute, this is not so bad. We have actually tripled the overall survival in locally advanced non-small cell lung cancer. I would caution you and say that, yes, we did make some progress between 1980 to 2000 perhaps, where we come up with chemotherapy and radiation, concurrent chemoradiation that improved the overall survival. Radiation therapy techniques got significantly better. We were able to give therapy to the full extent without radiation interruption or chemotherapy interruption. But then after that, I do think we have kind of reached a plateau. And the improvement you see here, in fact, the 2015 is the most recent RTOG Jeff Bradley study, where the overall survival is 28 months. What did we do in the study? Basically, the best arm of the study is what you've been doing it for 15 years. Taxol carbo on a weekly basis with conventional doses of radiation. So what really has changed? I do think the PET scan helped a little bit because we removed the occult stage 4 patients from being in this. So therefore, you're not finding the patients who get adrenal metastasis a month and a half after finishing chemoradiation. You probably pick them up a little bit earlier. That accounts for some. And you also have a new migrants coming from what used to be a stage 1 or 2, now being discovered to have stage 3 disease because of PET scan. So this is the classical Oklahomans and Californians, the Phil Rogers phenomenon. But that is not all. Actually, what has really happened, if you go back and look at the RTOG study, is that the median progression-free survival has been stuck at about a year, and we have not really moved that. What really has happened is that the post-progression survival has improved because we do have many therapies for our patients in the systemic therapy setting. So that has progressively, I think, has influenced this. And we have seen that not just in one study. We saw that in a number of studies over the past few months where we saw the 20s and no longer teens, but we see the 20s and now it's inching up to 30 months. So clearly it is not because of what we do in the stage 3 setting, it is because of the post-therapy. These patients don't die within a month, and they have many, many options available for these patients. So keep that in mind before chalking it is all up to advances in chemotherapy and radiation. You know all these data, I won't go into this, and that's the basis. And today we know that this is the best treatment, concurrent chemotherapy radiation. I had a bunch of slides, I took them out, and essentially we have done a number of studies that showed induction chemotherapy doesn't make a difference. Consolidation chemotherapy doesn't make a difference, and that's all you need to know. Regardless of what consolidation chemotherapy you give, the best example was docetaxel tested in a phase 3 setting. Induction therapy doesn't help. Concurrent chemoradiation is the basis of our current chemotherapy radiation program. And I just want to highlight 2 studies that you may or may not have seen. This is a PROCLAIM study, perhaps the largest stage 3 non-small cell lung cancer study that some of us led. Patients got conventional chemotherapy with cisplatin or investigational therapy with cisplatin, and the radiation therapy was fairly standard. And they got some more chemotherapy in the consolidation setting, but that's less important. What did we see? No improvement. In fact, cisplatin did not confer an advantage over cisplatin. You may say cisplatin is so 1970s and 1980, and how could that not be inferior to cisplatin? But that's basically what you see. And look at the median overall survival, again 26, 25 months, and so there's no reason to use pemetrexed. And by the way, we have done a number of pemetrexed studies. While it's a great drug to give in the advanced disease setting, I think it offers no advantage in stage 3 setting. The toxicities are not that different, and you do see enough pneumonitis and other problems, so there's no real advantage. But if you really have to give a non-taxane regimen that is systemically active along with radiation therapy, it's conceivable you can use pemetrexed. Cispemetrexed in the doses that we did, 75 milligram per meter square of cisplatin and pemetrexed 500 milligram. Carbo AUC of 5 every 3 weeks, and pemetrexed 500 milligram per meter square. Reasonable to do, but they don't offer any advantage here. The second is the important RTOG study, which asks 2 questions. Dose of radiation, 60 versus 74, addition of cetuximab, yes or no, in a 2x2 randomized fashion. Cut to the chase, both of them didn't make a difference. So the conventional chemotherapy that you have been doing, paclitaxel, carboplatin weekly with 60 of radiation, just as good. And if anything, there was numerically less. You can see that there was a possible adverse effect of the high dose radiation therapy here. So 28 months. So today, there's no reason to use higher than the conventional doses of radiation. I used to believe in the past that we should use cisplatin because that's where we had most data. But this study convinced me that paclitaxel carboplatin weekly is just as good or as bad as anything else. And I think both are interchangeable in my opinion. Cisplatin, the way all the cooperative group studies were done, or paclitaxel carboplatin, I think it's perfectly fine. If you compare them side by side, they are not the same studies. And if you remember that the PROCLAIM study had only non-squamous non-small cell because of pemetrexed, and the RTOG study, only half of them had that. And the PET scan was done in more than 90%. This is remarkable because PROCLAIM study was done in many, many parts of the world, and it is truly a global study with about 20% from the East Asia. And again, intensity modulated radiation therapy was used a little less frequently in PROCLAIM study, and the dose of chemotherapy, low dose of systemic therapy, doesn't make a difference, and the overall survival. Not to compare them one by one, just want to put them side by side. This is the slide from Dr. Sainin. And what is reassuring is that the radiation pneumonitis rates grade 3 or above is actually very manageable, less than 7%. Actually, I didn't 7% in the RTOG study and about 2 to 3% in the PROCLAIM study. And the esophagitis rate also has come down quite a bit. Truly a remarkable attribute to our radiation colleagues' hard work, and we have become much more, these therapies have become tolerable. What happens in real life? These are study data. Really, does it happen in real life? And this is actually Netherlands. I'm not sure whether Netherlands represents the true world, and but they have better supportive care therapy in Amsterdam for those who get chemotherapy. And if you look at the overall survival, you look at this about 20 months, and I'm sure we'll see those numbers here too. So it's really, we see that in the general population as well. And the radiation pneumonitis is truly dependent on the volume of radiation you give, and also there is some evidence that perhaps paclitaxel may add to this, and so I think it's important to keep in mind. Very quickly, those targeted therapies have really drawn a blank so far. Giving gefitinib to an unselected group of patients following chemoradiation was a bad idea, and it's still a bad idea with erlotinib or any other agent. So clearly this is important to keep in mind, the SWOG study. Adding bevacizumab to chemotherapy radiation could result in tracheoesophageal fistula. I've had anecdotally patients who received chemoradiation within a few months, got bevacizumab, still developed TE fistula because of perhaps radiation esophagitis leading to perforation. So be very careful in using bevacizumab in anybody who has had radiation in the short period before starting bevacizumab. So keep that in mind. Definitely no point in giving that along with radiation. Should we use PET scan after chemoradiation? I know it is used quite often in practice, and I actually don't use it in my practice. And this is an RTOG study where patients got chemoradiation. After that, they got PET scan to ask a question, would the PET scan be helpful in telling us who will do well, who will not do well? And these are the results. And post-therapy PET scan really did not identify a group of patients who did well or who didn't do well. So I also have a hard time interpreting PET scan post-chemotherapy and radiation, and I usually use conventional CT scan to avoid all these discussions. I briefly mentioned that surgery plays very little role in stage 3 non-small cell lung cancer. The big challenge we have in locally advanced non-small cell lung cancer is actually distant disease. In fact, 80% of patients when they relapse, they have distant disease, and we have to actually do better with systemic therapy. On an encouraging note, I want to highlight two studies. One, actually two types of approaches. One is a group of studies that are being done with immune checkpoint inhibitors following chemotherapy and radiation. Different companies are doing these studies, and I think it should consider opening those trials if you don't have them. I think it's an important approach to evaluate. We should do this carefully. We should not do this off protocol. And the other thing is that can we use targeted therapies in a selected group of patients? And that's the whole idea of the study that we are doing right now in the RTOG group, where patients with stage 3 non-small cell lung cancer, if they have EGFR mutation or ALK fusion, actually will be enrolled in the study. And the way the study works is very simple. If you have EGFR mutation, you get randomized to either erlotinib for 3 months, followed by chemoradiation, or chemoradiation alone. Why randomization? We don't know whether the EGFR mutant patients would intrinsically do better with chemotherapy and radiation. So in the absence of a control arm, it's hard to interpret that. Why induction, not concurrent or consolidation? We were very worried about the SWOG 0023 results, and we didn't want to give it even in the mutant positive patients post-chemotherapy and radiation. And in terms of concurrent chemoradiation, the studies that we have done in the past with gefitinib and erlotinib were not that exciting. The results were not that promising. So we thought we'll just give it an induction setting, eradicate the bulk of the disease, and come back and do definitive chemoradiation. Similar thing for the ALK. The study is open now, and it's open in about 600 centers, and has accrued about 22 patients or so. I need your help. Full disclosure, Billy and I are leaders of the study, and I just really would like you to consider opening the study. In fact, NCI told me yesterday that they're going to pay for screening, and they're going to compensate individuals and sites for screening. So hopefully this study will get something. If you don't do the study and the study closes because of poor accrual, such a study will never be done again in the future. And it's a very hard study to do, so we really would ask your cooperation and participation. So overall, we've improved. We have a long way to go. We've hit a plateau, and with all due respects, it's not going to come from tweaking the radiation. Radiation might help us get there a little bit more, may improve the toxicity, but real problems are systemic failures, and we got to do better with systemic therapy. And that won't come from rearranging the chemotherapy regimens or schedule. It has to come from a very novel approach like immunotherapy or a targeted therapy in a targeted patient. And also, I want to remind the people, a group of people here, that there is a big World Lung Conference in Colorado. If you can attend, that'll be great, and stay tuned for all the progress. Thank you very much.